So this, as I said, this is the first presentation on Safer Every Day. And Vicky asked, would I do a presentation on Scape? So I had a long think about it. And I thought, well, I will focus on Scape, but rather than just focus on that, I want to try and get out today where the Safer Every Day comes into it, and how having that little thought, sat in your office, sat on the ward with a patient or with a service user, how you can take it forward. So I hope that comes over in my presentation. So it's twofold, a little bit about that little seed and how you can take it forward, and the other bit obviously about Scape and where we came to and what we did. So just going back, I've got Jill's not doing any chat, she's over there on the right. Jill is Scape, okay, she's integral to Scape. She helps me take it forward. She's the one that does the audits with the team. I'll go into that, but I couldn't do Scape without mentioning Jill. So taking a small idea and making it HSC wide. So I'm gonna talk about that. So why did we introduce it? So if those of you that were around about 3 years ago, you'll know that we got a visit from the lovely NMC. And when the NMC came over, I wasn't a deputy chief nurse, I was the assistant director for the acute hospital at that time. And when Jackie Smith came over, Jackie Smith is the chief exec of the NMC, for those of you that don't know. And when she came around looking at maternity services, specifically focused on maternity services, she spent a little bit of time with me in the acute, so I took her around the acute wards. And one thing that Jackie Smith said was, all I'm hearing and what I'm seeing is a lot of good care, but how are you evidence that? How are you evidence in that? Because she knew that we didn't have CQC, which is what they've got in the UK. So she said, I'll be coming back in 3 months' time, and in 3 months' time I want to see evidence of some type of evidence-based quality tool here. So I went to my office, and I won't tell you what I said, but I thought, oh my God, 3 months to get a tool out to give reassurance, to hopefully that she'll say goodbye and I can show her what quality-based care we have. So the first point of call was I did a literature search. So I had a look at what's out there. I contacted a lot of my colleagues in the UK, you know, and what I focused on was, prior to your CQC audits, what do you do? What do you use to get ready for your CQC audits? Because I looked at the CQC tools, and they were quite comprehensive, and they didn't have that evidence-based detail that we needed. So I contacted a lot of trusts, and I kept going back to the same. I kept homing back to Salford. So Salford, prior to the 2 years, so prior to 7 years ago, me contacting them, they were a failing trust. They were a failing trust in Manchester. They got poor results from CQC, and they were put in special measures. And then 3 years down the line, they got good and they got excellent in some areas. So I thought, that's somewhere where I want to look at. I want to look at that. So I spoke to the chief nurse there, and she put me on to Fiona Morrison. Fiona Morrison had introduced Scape. She was brought specifically in. She was one of the quality assurance team, but she was took out of the quality assurance team to introduce something that will get them ready for CQC. She introduced Scape. So I had a long chat with Fiona on the phone. I told her where we were and what I had to do in a short period of time. And she was really lovely. And she sent me the Scape tool, but most importantly, she said, why don't you come over? She said, why don't you come over with a team? She said, the best thing is to actually come and see how we do Scape. Because what we do is we put on study days now across the whole of the UK for everyone to come, and because everybody started joining in. What we did, there was myself, Jill, there was the head of governance at the time, and there was another member of the governance team. We went across to Salford, and we spent a day there. And it was really interesting. What they did was we went in, and all the matrons were there. There was about 25 matrons, because it's a massive trust. There's about 25 matrons there, and we all sat on a table. And what they did was they went into detail on each one of the standards on Scape with us. But most importantly was they got up at the front of the meeting and started to talk about Scape and what it meant to them, and how initially it was really threatening because they were really scared of it, and you know, it was something that they weren't used to. They were used to the CQC coming in, but having internal inspections, they didn't really buy into it that much, and it took a bit of time. However, later down the line, so I think when we went to them, they were 4 years down the line with Scape. It was a complete buy-in from the whole of the trust, from the chief exec right down to the porters. Everybody lived and breathed Scape, because the Scape standards, well, the Scape format can be used for any discipline. So I know that I could, with the help of Janine or Maureen, we could adapt Scape to cardiology and to pharmacy. You know, the actual format of how it works, you can adapt it anywhere, and that's the thing that I like, because we are health and social care. We're not just an acute trust. They've just gone to community as well, Salford, so they're developing their community tool. So we spent the day there. It was really inspirational, actually, because then the matrons come in. They had the red top, so the matrons, the wards had actually got Scape status, so they deemed that as a ward of excellence, went into a bright red top, you know, and they were really proud of this bright red top. However, and I'll chat a little bit about it later, if on the following year they didn't get Scape status, that was all took away. So it you know, it has its good points, but you've got to maintain it. But actually, it was really good, and we went round the wards and we've seen all. Most importantly for us, from a governance and quality assurance perspective, we actually seen the standards on the wards and in the department, because he said that standard is that. See that one? So it was really good to actually see. It wasn't just a paper exercise. It wasn't just a tick box. You started to see the productive ward modules. You started to see everything in practice, and everywhere you went, it was Scape status. What is our Scape status? It was just embedded. So we all came away thinking, right, this is great. Really realising we only had 3 months to try and turn it around. So we sat down and we said, right, how are we going to do this? How are we going to take it forward? So what they did in Salford is they have 2 people dedicated to do it. This is their role. So from Monday to Friday, every week, that's what they do. They just do Scape across the whole. We didn't have a budget. As usual, we didn't have a budget for Scape, so we had to do it within the resources we got. So luckily I was supported at that time by the interim chief nurse, Steve Hams, and Steve, who was head of governance as well at that time, said I could have help from the governance team to do this, to bring it in. So that's sort of how we work. We had the standards from Salford. So we sat down. I have brought, for those of you that have never seen Scape, just pass that round, Alison. This is what the tool looks like. So what it is when you've got an idea, it all sounds good and it all sounds interesting. It's only when you start to unpick things that you think, oh my God, we need to do this. And so what we found was, when we got the Salford tool and we looked at the standards, and we chatted to the matrons and the operation managers and our maternity colleagues, and we chatted to everybody and we looked at it. Out of the standards, I can't remember off the top of my head, so say there's something like 89 standards in total. We was actually at a point at that stage where 58 standards we'd not implemented here. So we sat down and we said, this is going to be really, really tough, because we're going to go out and we're going to do an audit, and staff haven't got compliance. We've never discussed it. So it was back to the drawing board. So we had to take a step back and said, right, okay, at this point it's not worth us doing the audit, because we're going to fail completely, because lots of the standards in there, for one reason or another, and we do not know why, we really hadn't kept up with the UK. We hadn't kept up with all the new guidance that comes out and all the new standards. We were way behind, absolutely way behind. So I can't remember who came up with the idea, but somebody came up with the idea, why don't we have a working group, a Scape working group across the whole of HSE? And what we'll do is we'll get all the standards, we'll look at the standards that were not compliant, and we'll start working on them. Julianne, you was involved in that, wasn't you? There was about 58 standards. There was loads. What? There was just loads and loads. So what we did was we picked out all the standards that we knew we were non-compliant and that we needed to get out. And what we did was we started a subgroup from that group to start to work on getting it in. And I can tell you this was all done in a matter of 6 to 8 months, and then we just said, right, okay, do we just go for it now? Because we've not got 100% of the standards done. We also had a debate about taking some of the standards out that we knew we didn't have, but the group were really firm behind this, and I want to praise the Scape working group for this, because they said, no, don't take them out, Elaine, because we want to achieve them. It would be harsh on the wards and departments because we knew it was going to be a no. But the working group were very much no. Ultimately, that's where we want to be. Leave them in. So we did. So we left them in. And we did get a lot of backlash from the wards and departments because they kept saying, you know this is a no. You know we've not got it. So that was that. So just looking at 68 standards and how are we going to engage with staff? I have to say at that time it was a really difficult time. Morale was really low at that time. Every week I felt like we were the front of the press. There was something about, you know, either maternity services, our maternity colleagues were getting battered. Then they started on the acute, and it was a really bad time to try and motivate staff. But you know what? They were absolutely amazing. They really impressed me, because what I found bring it on. Do you know what I mean? Let's do it, and let's prove to not only the public, that's the most important thing to us and our service users, but let's prove to the NMC that what we are saying is right, our care that we do deliver is good, and what we can do this time is evidence-based. So, you know, the staff were absolutely amazing, and it was a really difficult time to introduce change. So for any of you that have them little ideas, time's never right, and don't be put off by somebody saying we can't do it now, we're too busy, or we've got no staff, or it's half term. You've always got to just go for it, or you'll never do anything, and you'll be where we were 3 years ago. So I love this PowerPoint. I didn't do this, somebody did it for me, but that's very good. James, very good. So we used the senior nurse comms, we had the blog, we did a trial. That's so important. You know, if you're thinking about doing any type of change, don't be afraid of the feedback you get, because the feedback you get from staff is so important. Don't take it personally. Never take it personally, or you'll never do anything. You know, this is rubbish. This is UK based. Okay, you sit down with them, you engage with them. Quite often, it's a fair point. You know, and you change it and you go back. Then we needed CMT engagement. So that's a senior management team engagement. So I did a paper. I took it to the paper, and they were really supportive of it. So that was sort of from having that little seed that we needed to do something and we needed to prove something, to where we took it. So what does Scape look like today? So you've got the document going round. We have altered it considerably over the last, started in 2015, we've altered it considerably over the last couple of years. The thing that I absolutely love about Scape, I should have put it up, is I think page 4 or 5, it's got all the standards in it. It's a 15 standards or 15 standards in Scape. So every year, January is our month out, okay? So what I mean by that is we don't do any Scape in January. So say for instance, the medication standard, I will send that to Janine, and I will say to Janine, is there anything you want to add Is there anything you want to add and update? Infection prevention, send that to Kay and Arlene. So all the specialists and the consultant nurses, they get sent the standards to update, and that keeps Scape live and it keeps Scape evidence-based. We go through it as well as the governance team. Every time, I can't tell you now, so this is 3 years down the line, so every time the guys do an audit, they come back and they say, do you know what, we've got to change this, or so we're constantly changing it and constantly updating it. So this year, for instance, we've added a dementia module. So the dementia module is the very last one. And what we've done is we're not going to assess that one this year because it's not going to be fair. So you've got the wards and departments have got a whole 12 months to know what them standards are and to reach them. So that's sort of the premise to it. The standards are medication, there's care, so we look at the environment. How does it feel? How, do the patients look well cared for? Do staff come up to you and say, hi, who are you? Do they check your ID? So we're looking for all stuff like that. So that's it, 15 standards. So who are the auditors? So we did a different approach from Salford, mainly because we didn't have the finance that they are. But actually, I like our model better. I actually like our model better. So we have one consistent person at every Scape audit, and that is Jill. Jill does all the Scape for consistency. There's always another member of the governance team, and then we put it out. So every single one of you today could be part of the Scape audit. So one of the audits, you just contact Louise Loveridge. So Scape audits, to do a Scape audit is open to everybody, and we love that. When we initially started it, we had a lot of the ward managers doing the Scape audits, and I know the feedback from them was, and this is what we wanted, was that they learnt a lot. So they went to a ward and they thought, oh, I really like that. And you wouldn't believe we are so little, we've not got, 100 wards, but they learnt so much. And they like, oh, I love that notice board, or I love the way they've got that leaflet. I love the way they do that handover. So that was the reason why we invite people into Scape. The other thing is they give us fresh eyes. So they bring things that we sort of miss. We do a Scape audit every other week, so we're doing one tomorrow. So like the CQC, we just give you a day. You will get a day's notice. They give you a little bit longer. We give you a day's notice. So Jill will email you and say, hi, just to let you know you're going to be Scaped tomorrow. That's when hellfire rings. And they, and everybody says, oh, we've got Scaped tomorrow. We do that now because of the written documentation, so you can gather that for us, and that makes it more slicker. That's worked a lot better, hasn't it, Jill, doing that one? So I'll give you, we never ever defer from the day we're going to do the Scape. So you can tell us you've got no staff. You can tell us, which has happened today, we've got agency running that ward to Maury Lane that you're auditing. Not bothered, we're auditing you. Because we've got to take it like it's a CQC audit. And that's one thing we will not defer from. But you take that, because we'll pick up everything on that audit and we'll help you. And we'll pick up that you're a ward running on agency. And that's not acceptable. So take it for what it's worth. But we never cancel a Scape audit. Never, we do stick to that. So so the guys will go on the wards. We usually start about 11 because we like to get lunch. So we look at what they're having for lunch. Is it appropriate? Do you like it? Is that what you ordered? There's a lot of patient engagement. I know that all the audits that I've done, the patient feedback is always amazing. And it always reassures me in this role because it's so good. It's absolutely so good. So I love that bit of it. If there's anything that we see in the audit, we raise it straight away. Okay, so any concerns that we have, we'll raise straight away. I try and turn the audits around in a week, if I can. It depends what my workload's like. So what I mean by that is you'll get the audit tool completed with recommendations within a week. Because they're always battering down my door. What have we got? What have we got? What have we got? So yeah, that's just a little bit about the audit. Ellen's going to chat a little bit. Ellen and her team are the very first wards throughout the whole of HSE to get what we call this blue Scape status. Now, blue Scape status is deemed as a centre of excellence because they've reached green Scape status for 2nd and 3rd years on the run. So it's maintaining them excellent standards. So Ellen's going to do a presentation. So when you get that blue Scape status, it's provisional on you doing a presentation to the chief nurse and the medical director. And the presentation that Ellen and B are going to give are the presentation that they gave. And I have to say it was absolutely amazing. The whole team presented. I think you'll get a lot out of it, especially those of you that are coming up for Scape status. I think you'll get a lot out of that. So Ellen and B will do that in a little minute. So they present to Juliet and Peter. So just so you know, just because you've got that green Scape status, it doesn't mean you'll get the blue. So if Juliet sees things and Peter sees things like medication errors that are really concerning, but ultimately you get your green with your score and you won't get blue Scape. The other thing that we've started to look at now is the audit, because the audit was obviously done for an acute ward. So we've had for instance, our maternity colleagues have turned theirs into a maternity Scape standards, and it's amazing and it's great and it means something to them. We've still got some wards and departments that it's too acute. So again, every time I feed back, I say, if you was coming up to blue Scape status, I want to see more standards that are relevant to your area. So to make it more meaningful, okay? Because the NAs are like a yes, so they're not applicables are a yes. So we are starting to push back now and say, look, you know, for instance, DPU, we did them recently, didn't we? And I know Paul won't mind me saying, but there was nothing in it about endoscopy, minor surgery or recovery. So, you know, you're not going to get blue Scape. You've got to go back and add them in. And the team can turn that round for you really quick. So when you do get it, so Ellen's going to go into a lovely red top, which she probably hates because red's not a unforgiving colour. And all the staff have got the red lanyards. They were presented at the committee by Heidi. So it was really nice, and it's a real achievement. The biggie is that Ellen and her team have got to maintain it. They've got to maintain it. You know, if they get amber, then it all goes away. So it's keeping that standard up. So we develop the action plans and we get them out. Now, if I'm talking to you about Safer Every Day, this is the one thing that I know that we failed on. So what I mean by that is we do the audits, we give you the recommendations, but the governance team, we don't follow up on that compliance. So what we don't do is, because I will put in the audits, I need feedback by March, okay? And because we go on doing the audits and you get involved in everything else, you don't do it. This year's going to be different. This year we're blocking out when your audits are due and we're going to chase you up. So at the back of the Scape tool, it's got the recommendations that I write, and then it's got your bit that you populate, what have you done about it, how you're taking it forward. So we're going to tighten that compliance loop this year. I think Scape's just escalated and escalated. It's just been difficult to tie it up. But Jill's point was really good before, in that when we do re-audit the wards, we do see that compliance, because we do look at the audit tools. I know that before I do the audit, I look at the audit tools and I look at what did they fail on, what the recommendations that I wrote in. Quite often I'll stick that in my pocket, that 2-pager, because I don't really want to see that again a following year. Some of them are out of your control, like estate stuff and that, so that's fair enough. But compliance is something that you need to do. If you're thinking about a change, you need to go back and look at it. So we are getting a little bit better on that. Okay, what would I do differently? So I'd make sure my compliance was better. I didn't have time, but I'd do more staff engagement. I really would. If I had my time over again, I'd do a lot of the stuff like we've done with the Falls Bundle. So we've had lots and lots of meetings, lots and lots of engagement. With this Scape, it was just thrust upon you. It really, really was. I would do I do drop-in sessions. I do a lot more than we did, but we just had a short period of time to do it. and review the scoring system. We just adapted Salford's. We've changed it a little bit now, but as I say, we was in a good. So what's the future? The future of Scape. Mental Health have developed their own tool this year, and they've also gone out into the community, which is absolutely brilliant. They've got a community mental health tool. I'm working with Jane and Linda in the community. So we'll be developing a community Scape tool going forward. Theatre Scape tool. I got one from, where did I just been? Morecambe Bay. So I'll give that to Jill. So we're looking at developing that one. And ultimately, Scape, I see, we will in the future be regulated. Okay, so that will be like a CQC. That is coming in. We're writing law this year. Okay, so there will be a type of regulation, a bit like the CQC, but we want to make it more quality focused. The law will have to be done by the end of this year. So I see Scape really as us getting ready for it, so that when that law does come in, we're ready. We've got them standards ready. So I do think that Scape is here to stay. And like I said before, happy to discuss anybody that wants to introduce Scape in the area that we've not done it, because it can be adapted to everybody. And now I don't think it's as scary. I'm sure the wards might say something different to me, but it's just about standards and showing how good you all are out there. I'm going to pass you on to Ellen now. We'll go straight into Ellen and B, and then we can take questions together. Is that all right?
Hello everybody. So for those who don't know me, I'm Ellen Waring. I'm the ward manager on Brayon.
And I'm Bay, I'm the staff nurse on Brayon Ward.
So as Elaine explained, we had 3 consecutive green Scape statuses, which allowed us the opportunity to present to the panel for our blue status. I think we had our 3rd green in October, we presented in November, and the end of November we got our blue Scape status. So the presentation we're going to give you today is the presentation that we gave to the panel. For people who don't know, Brayon Ward, we are part of the Older People's Service that encompasses both general and mental health nursing. We're an older adult unit caring for people with long-term or transitional or respite care needs. We have 2 respite beds at the moment. The majority of our work is with long stay, but we do also take transitional from the Princess Elizabeth. It's perhaps people waiting on nursing home beds, but the majority of our work is looking after people who require hospital level care. We don't just look after people who have dementia, although some of our residents do. We also look after people who have complex medical conditions, who perhaps have tried the private sector, been in nursing homes, can no longer be looked after in the community, and require that little bit more expertise in looking after them. We're primarily nurse-led, with support from psychiatrists, GPs, and we do have a consultant geriatrician. We're quite lucky in the fact that we have dual consultancy on the ward, so we have regular input by one of the consultant geriatricians, but also the consultant psychiatrist as well. We have capacity on the ward for 20 patients at one time. Really, the crux of any ward is the team. So just to break it down a little bit for you, we have 38 members of staff in the team. The team is comprised of registered nurses, associate practitioner, healthcare assistants, nursing auxiliaries. I have a nutrition assistant on the ward, an engagement nurse, and of course we have our regular housekeeping team. The great thing about any team is all the different levels of experience, the different knowledge that people bring, and the different skill sets. We're all different ages, we all come from different backgrounds. Currently, I only have 2 unregistered nurse vacancies. I now have 1 registered nurse vacancy, which we didn't at the time. We're an active student placement. We take students regularly on the ward, and the feedback tends to be always really positive from students. Supervisory status is still, for me, a little bit in the distance, but hopefully not too far on the horizon. So we looked at just a few little bits in between. thinking of our team, I can do things you cannot, you can do things I cannot, but together we do great things. And I think really that sums up what my team is that we're all made up of different people, we all contribute something differently, but actually something works with our team.
We just discussed in the meeting where we presented just about what makes our team a team. So just generally we've got some points here, like Ellen was saying, we're very passionate about the care that we provide. I think you have to be passionate to be a nurse anyway, but we're very passionate about older adult nursing. We're also very caring of each other, we look out for each other. We're very good at communicating as a team as well. We respect each other, support each other, and it's an area where you don't feel afraid to speak up. You don't feel afraid to say, I'm not happy with this, or this isn't right, and people are encouraged to speak up if they want change, because without speaking up, change won't happen. Discussing leadership within the team. So one of the reasons that we got to where we got really essentially was that we have very good leadership. Stood here to my right hand side. So we have at the core of our team, we have Ellen. I think a good team comes from having a very good manager, a strong manager, but also someone that is approachable. And I think that's one of the most important things really, is that you can approach them whether it's a good or a bad. With Ellen, you can approach the negatives. We celebrate the positives, like we've celebrated our Scape status as well. But having that really strong leadership is just essential to what's, I think, made our team a very strong team and enabled us to get the status that we got. I'm a junior member of staff, I'm newly qualified, I'm encouraged to coordinate shifts from the very beginning when I started, and I'm just very supported throughout by the whole team. And we have nurse-led doctors rounds, which is very nice, and we also have an extremely good doctor who allows us to have those nurse-led doctors rounds. So we get so much input because essentially we know the patients so well that works for us. So leadership is about caring for people and being a useful resource for them, being present for people and being your best, most authentic self, creating a place in which people can do good work and find meaning in that work. And I think that people, when they've come to work where we are, when you go home you feel like you've done everything you can do. You don't feel like you've left something, you feel like you've done all that you can do. So
what we did next is we broke down the 3 Scape audits that we had. So the first one going back to October 2015, and we looked at the different aspects of Scape that sort of needed to be put into an action plan. So looking at the first one, it was things like looking at an equipment inventory. We just didn't have a list available on the ward that itemised every single piece of equipment. I think for most departments that's quite hard. Equipment gets moved from one department to another. So we just didn't have an up-to-date list. So we had to do that. We've now got one on the ward. We looked at the emergency grab bags because being outside of the main hospital, we don't have the big resource trolley that a lot of the acute wards have. We basically had a collection of equipment in various drawers in the treatment room, but we all recognised that actually as an older adult directorate we needed something much better than that. So we looked at that, we involved Mark Mapp at the time and John Atkins, and they got involved, and we now have these emergency grab bags on the ward, and we have them on all the older adult wards. Intentional rounding, we knew we did lots of things, we just didn't have the documentation to evidence it. So now we do, including things like sleep charts, repositioning charts, hydration charts, we have all of that. We fall outside of the regular hospital PGDs, so things like, for instance, the oxygen PGD, currently we're not covered by the main hospital one. So what we then had to do is looked at having everybody prescribed oxygen, looking at what the parameters were for their saturations. We did that in conjunction with the doctor, and that was then sorted. There was lots of changes at the time around the reporting of pressure sores. You did it at grade 2, you did it at this, and then all of a sudden you did it at every grade. It was a little bit of communication and a bit of education for the staff on exactly what we had to do. So we made sure everybody knew what the processes were, and that was then put into place. At the time of this audit, we didn't have a catheter on the ward, so we weren't using the catheterisation pathways. But what we did do is, even though we didn't have catheters, we made staff aware of the catheterisation pathways. Now we have about 6, so we're using them regularly. The other thing which we addressed with both nursing staff and housekeeping staff, that obviously when a room became vacant, it needed to be cleaned. We had to introduce these room is clean stickers. They're now done. So that was 2015. We then moved on to February 2017, where thankfully all the issues from the previous audit didn't come up on this one because we had reviewed the previous action plan and addressed those issues. But there were a few other things that did come up. So for instance, all of a sudden we were talking about supervisory status, and I think at that point no one had supervisory status. So that one there was still ongoing. The introduction of the pain link nurses, and we were needing to look at having a pain resource folder. We didn't have that at the time. I think Elaine did this audit actually, and it was Elaine responsible for finding the one and only sharps bin on the entire ward that didn't have a date and signature on it. So that was one thing that did get picked up. Transparency board. Transparency boards that you guys all have in the hospital, we haven't had anything like that in older adult or the continuing care areas, so that was an issue that got brought up. The power service contact details weren't available. We didn't have a printed out list or access or were aware of the high risk medication. Palliative care study days, that was a real issue, which staff hadn't been accessing study days, but actually study days hadn't been available, but that was highlighted. We looked at some of the medication charts, and there was, I think on a couple of the drug charts, there were areas that things hadn't been signed, but there was no omission codes written, so there was gaps. And it was around the introduction of, around the time actually, of the introduction of the skin bundle, which we were in discussions at the time with Ellie Phillips, because the problem we had on a ward like Brayon is that actually everybody's high risk of pressure damage. So effectively everybody is on the skin bundle and everybody will be requiring that input. So the issue we had with that was the time aspect of it. You've got 20 patients all requiring frequent pressure care and pressure repositioning. It was going to be quite a task. So most of those were straightforward. We did some work with Ellie, and we actually looked at redesigning a repositioning chart for our actual area, which made it much more user-friendly. It was much more user-friendly for both registered nurses, but also for the HCAs and the nursing auxiliaries who do a huge volume of hands-on nursing care. So it had to be something that was adaptable, but actually usable for our ward. That takes us to our last one, which was in October last year. And bearing in mind we'd worked on everything else that had been recommended, these were the 3 areas that came up that required further action. The first one, again, being the supervisory status, that it's still ongoing. I'm still not supervisory. I don't know if all the other ward managers are still there. So that is still ongoing. The transparency board for the ward. Elaine and I had lots of conversations about this. I joined the older adult directorate up here about 5 years ago. My understanding was previously there'd been a lot of reluctance, I think, to introduce the transparency boards, but actually Bay and I together are looking at it and seeing how we can introduce it into not just our ward but into the older adult area, but actually make it something that is useful not only to us as a team but also to the relatives and the service users that we look after. We're a very different environment to an acute ward. The turnover of our patients is much lower than everywhere else. The expectations, I think, of the information that our relatives want to know in comparison to someone else is very different. So we wanted to ensure that an actual transparency board wasn't just something pretty on the wall that looked nice, but that actually served a purpose. So that's something that we're actively working on. The other issue again came up was about palliative care training, and in this audit it said that at least 50% of staff should have access to palliative care training. Again, that was an organisational issue because there's just nothing. I think there was basic talks on end of life, but that was really it. And I think there might have been a couple of bereavement sessions, but that was it. So we did contact Karen Leach, and I know Karen is actually looking at that for the whole of the organisation to see what palliative care training can be put in place.
So managers supervisory status. So with regards to Ellen being supervisory, it will be viewed as a very positive step for all the individuals in our care, as well as us as ward staff, for the level of support that we will be able to get. We just need an additional registered nurse in order to allow that to happen. And yes, it would just allow greater accessibility really for family and everyone to be able to access that. Transparency board that Ellen was discussing. So we want to, like Ellen said, we want to make it ward appropriate. So it's just the kind of deciding what's going to be on there. I think Ellen is sort of liaising in with families as well to see what they want to have on that. We're thinking about maybe having names and photos and things like that, just making it a lot more personal to our ward as well, and compliments and complaints as well, because we don't move forward unless we address what's not working or what's not worked. Palliative care training, so it's not been available, it's still not available at this stage. We are actually Ellen contacted Katie Bassett, who was very kindly giving Ellen a lot of her time to discuss pain management, and we've now got quite a very good resource folder for that, and also we obviously can contact Katie like anyone can to get extra information. And we are trialling at the moment the end of life care plan. We are one of the wards that is trialling that as well before it goes out. So other developments and initiatives, I think it's just really good to celebrate what we have in our ward. So we have ergo coaches in our ward. We have free untrained member of staff who are ergo coaches as well. So they're given protected time to deliver the training and assess staff's knowledge, skills and competencies. And the best thing about this really is that it's done on the ward, so it's ward appropriate with regards to the types of hoists that we use and the individuals and their moving and handling needs. The other thing is that at any time, I just had an impromptu session a couple of days ago with someone. If you have the time, we just have it there and then. We'll just go through different manual handling and what we do with individuals, so it's very individualised. We have a nutrition role. We have a nutrition lady called Kathy. She is integral really, because of a lot of the individuals in our care aren't able, they need assistance to have for all the nutrition and hydration, and this just allows us to keep on top of things, and it is essential. And then we also have Carmo, who's our engagement coordinator. We have a sensory room now in our new, because we're the third bungalow up, we've moved, and we can utilise our sensory room with Carmo. She also does patient-specific activities at varying sort of levels or whatever everyone wants to do. So yeah, we're very person-centred ward, because a lot of the individuals that come to our care come and stay for a long period of time. We're able to get to know them extremely well and get to know their families very well. Ellen and I were just discussing before about getting to know families even better. They're not able to visit sometimes, or they live in the mainland, and it's just about recognising and valuing every individual, what we can do for them, what we can encourage people to do themselves, seeing the person, not the condition. And we use the This Is Me booklet, and we're trying to get patient passports for every individual, just so that for example, if there was a transition into hospital, it just make that transition a lot smoother.
So really, just to finish off, I was looking the other day, because the team actually won the Angel of the Year award this year with the Pride of Guernsey Awards, and I was looking back over the nomination that went in and the written document that came with it, and I was quite surprised how much of it was actually a lot of the aspects that come through Scape. So a lot of the comments that were made about staff related to the fact that they're very patient or person-centred, that they're very respectful and very dignified in the way in which they care for people, that they go that extra mile, that they actually care for each other, not just the patients. And actually, yes, they know they do a really good job, but they don't sit back and they don't accept that that's it. They're always looking to see how they can possibly do something better. So for me, the immense pride I have actually in the team that I work with is the fact that actually they kind of make coming to work not like going to work, because people say the job of a manager must be really difficult, and yeah, you have your days, and I'm sure they would agree. Sometimes they probably want to strangle me, and probably sometimes I want to strangle them, but actually they make my job quite easy because they are an incredibly good team. And I think the centre of it all is they come in every day to do the best they can, to look after the patients in the best way they can. Some days are really difficult. I'm sure you've all had good days, you all have terrible days, but they come in every day with the same positive attitude. They don't come in thinking, oh my goodness, is it going to be terrible like it was the day before? They come in with the exact same attitude as they came in the previous day, expecting it to be good, disappointed if something disastrously happens, but then that's it. They come in the next day and they start again. And it's hard. If anyone's ever worked in continuing care or older adult, it's really hard. It's physically demanding, it's emotionally demanding, it's like everything, it hits you everywhere. But you wouldn't know it. If you meet this team, you wouldn't know it. And that's, as a manager, that's where I'm most proud. And Bay mentions about having a good manager, but actually it does, at the heart of it, goes back to actually having a really good team, that actually you can't do one without the other.